that. So you have to look for subcutaneous nodules in this scenario. Then fourth case was basically about an interesting scenario of isolated thelarchy. So this was a girl with isolated thelarchy whose basal LH was slightly elevated, but after GNRS, the LH went up to around 7. Now, what most people thought that we should do an MRI head, this is a progressive puberty, but remember that we need to have different cutoffs for LH in younger age group. So here we can go up to 8. So this was a trick question. If your GNRS stimulated LH is less than 8, do not rush, follow up. This is an isolated thelarchy. That was the message which we wanted to give to this question. The 6-year-old girl with vaginal bleeding, and this was a girl with short stature with vaginal bleeding, good breast development, no pubic hair development. So this was the von Wieck-Grumbach syndrome. Thyroid levels was basically very, very high. The question was that why did she not have pubarchy in this case? So clearly in hypothyroidism, why don't we have pubarchy? Anybody would like to say, Dr. Priyanka? So your bone age is less, so adrenals are low. Your prolactin level is high, so that's why your LH-FSH levels are low. So delayed bone age, high TRH causing high prolactin, and reduced LH. These are all true. There is no effect of TSH on adrenal. So this was the wrong one out from that regards. Then this was a case basically of a hyperosmolar coma. So this was more based upon the ADA guidelines. So this was a clear-cut case from the guidelines as to how would you manage. So the management was basically bolus with half normal saline, correct over 48 hours and replace urine output. That was the maintenance food recommendation for hyperosmolar state. So this was a straightforward question there. Then this was an interesting question. This was a boy who had found to have low BMD Z score. Now the question was, which of this would not have caused a low score? This was an interesting question. So if you say bone length is less, you expect this will decrease the falsely have a low level of bone density. If bone age is delayed, bone density will be falsely low. If you have prepubertal, again the same. If you use adult software, it will actually overestimate. Your value should have been higher. So this was clearly a case which was not erroneous in that regards. This was again a case of hyponatremia because of something for which 3% saline was given, and there was a very rapid rise in sodium. So what do we do in this scenario? Very rapid rise of sodium. We want to relower it. So this is how you can either use a 10% dextrose or you can use a DDAVP. So other options were stop saline infusion. It is not going to help because it's not going to relower. Reduce infusion rate will not help. So answer was administer DDAVP, or you can give 10% dextrose. So our aim is that it should not rise definitely, even if it is acute, beyond 12 millimoles. If it's chronic, it will be less than 6. So here you go for relowering. That was the trick question in this scenario. Then this was again our conceptual question about hyponatremia and water deprivation test. Now what this child had was a nephrogenic DI classically, but he had developed vomiting, and after that the urine got concentrated. So this is non-osmolar stimulus of AVP secretion. Your AVP becomes very high when you have nausea, and some concentration will happen. So this was again showing that this is not nephrogenic TI, but because of nausea, the AVP levels went up. Next question was basically very interesting, in which you're on some follow-up report. T3 is high, T4 is low, and TSH is low. So Dhwani? So this is now Lenormand is available. This T3 is available, and often people are using that drug. So your T3 will go up, T4 will go down, TSH will go down. So very unusual combination. So this was because of triiodothyronine treatment. Then this was basically a case of, again, a very, very important case of Hodgkin's disease. So on Hodgkin's disease, this child has subclinical hypothyroidism. So why do you want to treat this case, even if they're STPO negative? Alapan? Yeah? So there is a very high risk of malignancy. So you don't want any TSH elevation. So in a patient who has been exposed to radiation, subclinical hypothyroidism has to be treated. That will be the message from this regard. This was intensive care, septic shock, and this was a scenario of low T4 and low TSH. Now, the question was whether this is central hypothyroidism or something else. So, we asked which of this does not suppress TSH basically. So, hydrocort does, dopamine does, shock does, dobutamine does. So, it was more like a theoretical sort of a question. Now, this was again a very interesting question. A case who was diagnosed as central hypothyroidism earlier because of low FT4 and a TSH which was low was started on treatment. On follow-up, suddenly the TSH went up. So the question was, why was this happening? So this means that the initial TSH was falsely done. It was already high and this could be heterophile antibody. So this was a scenario from there. Then this was a case which we were discussing just now as to what sort of doses we should use based upon the FT4 levels. So here the FT4 was 6. So because of that, we are talking about 10 to 20, 12.5. So if the FT4 is below 5, it's 12.5 to 15. 5 to 10, it becomes 10 to 12.5. Below more than 10, we say you can start off around 10 or even 8 to 10 may also be good enough. So FT4 based initiation of thyroxine therapy in the newborn. That was the concept there. Now, this scenario was basically a scenario of non-classical CAH. You had a lady who had 15-year-old girl who had mild hirsutism and non-classical CAH. Now, whether you give hydrocort or whether you give estrogen progesterone, which one would you like to give? Dr. Yasmin? So the Endocrine Society says that in milder cases, no point giving steroids, it will cause more harm. Better to treat it like PCOS. So there you can give estrogen progesterone. So even if you diagnose non-classical CH, it's not going to make a huge difference in this scenario. Then Turner syndrome, at this 14 year of age, the question was what sort of preservation you will do. AMH was detectable. So you can now, after 12 years of age in Turner's, you can go for oocyte preservation. Although, remember, this will need induction of ovulation. This will need a lot of invasive procedure transvaginal. So it's a difficult one, but you can theoretically do a oocyte preservation in this scenario. Now, this was a very simple case. A child whose fasting is slightly high, PP is not increasing, and HbA1c is 6.5. Lean child, mother also has a similar illness. So this is clearly a case of glucokinase deficiency. As against all these are transcription factor MODIs. In transcription factor MODIs, fasting may be normal, but post-meal readings will really jump up. That will be the major difference. Is insulin level. You can have zero insulin in 20% cases. So the best marker actually is a low ketone level. So if your ketone level is high, then your hyperinsulinism becomes extremely unlikely. Then we had got this child with refractory hypoglycemia, and this is refractory hypoglycemia. Insulin is high. The child is not responding to diazoxide, and you do a genetic study. Genetic study shows a paternal mutation in potassium ATP channel. What does it mean, Dr. Saji? So paternal mutation means more likely to be a focal disease. So that is why this was a sort of algorithmic question. So if you have a focal disease, you go for a fluorodopa PET. If it was okay, sorry for the confusion. Very forward with the questions. So this was a child. So we were discussing about the sick day guidelines as to how do you give the extra dose in this scenario. So this was a scenario in which there was an issue about bone health. So again, the most important thing is if your ALP level, what level of ALP should you be worried? 1000. More than 1000. And if your phosphorus is below 4, this is what you start worrying about. This phosphorus of 3.6 was clearly on the lower side, which was there from that regards. Then the next question was, if you are on multiple predatory hormone deficiency and you're starting hydrocortisone, which all dose will be increased except. So you would expect growth hormone dose to go up because you will have growth suppression. You expect thyroxine dose to go up because whatever TSH is there, it is going to come down. DDAVP, what will happen when you treat? Again, AVP will be suppressed. So cortisol suppresses AVP, TSH and GH. So all three will come down. It will have no effect on estrogen basically. So that was the message there. Then 12-year-old boy with weakness, lethargy. This was basically a scenario of SIADH. In SIADH, when you give them sodium chloride, the sodium level will actually come down. Now, what is the explanation, Dr. Pradeep? Yes, so body is already prepared to push off whatever sodium you take, it will push off. So basically your ANP level is very high, that's why it is pushing off. AVP high is not going to make a difference. Other factors, of course, because of high ANP, aldo is low and low osmolarity of urine will explain this finding. So this was the basis there. Then this was a child with 3-week-old child with dehydration and small adrenal. So this was clearly a case of adrenal hypoplasia congenita, AHC, because of DAX defect. So in DAX defect, we expect other X-linked disorders like Duchenne muscular dystrophy. We expect hypo. There may be an enlarged penile size to begin with, but IUGR doesn't happen. Which form of adrenal insufficiency causes IUGR? Image syndrome, we will have that, but not for this form of that. Then there was a 3-month-old boy who presented with failure to thrive, dehydration, skin rash. So this was pseudo-hypoaldosteronism because of the epithelial sodium chloride channel. The question was which is not effective. So we use high dose of fludrocortisone, yes. Carbenoxolone is effective. How does it work? 11-beta HSD, it inhibits that. High dose hydrocortisone has got no role in this scenario. Then 2-week-old child presented with atypical genitalia. So this was a XY-DSD with hyponatremia and hyperkalemia with a low level of testosterone. So the further classification here will be whether this is a star defect versus 3-beta HSD. Their DHEAS will be the investigation of choice, which we'll have to look forward in that regards. Next question was a case of GHD with severe growth failure. Once you started growth hormone, there was good response, but now the response is very less. We discussed about this. This could be an antibody against growth hormone because of GHD 1A, in which you can have that scenario. Now, again, this question was discussed today also. A girl whom we are treating with IGF-1. The question is, why is growth hormone a better growth promoting therapy than IGF-1? The answer is that growth hormone has a direct effect on the growth plate. It increases the IGF-1 half-life because IGF-BP goes up. There is less risk of hypoglycemia. and higher Phe IGF-1 is not a cause there, which is not there. Now, next question was a case of pubertal development with cafe au lait spots. But there was a catch here. What was the catch, Alapan, here? So there was regular patch and LH is high. So this is not McCune-Albright. This is NF1 related optic glioma. So in this case, you should do an MRI head rather than other workup. This was again a case which always people tend to do wrong. I don't know why. This is a case in which there is a lot of genetic information about the parents. What are the various mutations? All you have to do is that there is a 25% risk of CAH. And that when it is girl, it will be 12.5%. But every time I find this answer is always wrong. Usually people will. This is simple genetics question from there. Now this is interesting. 18-year-old girl with secondary amenorrhea, very lean individual. So this is a case clearly of anorexia nervosa scenario. And we wanted which endocrine profile does not fit into there. You expect a high growth hormone, low IGF-1, growth hormone resistance. You expect stress, high ACTH cortisol, low T3, T4, TSH you expect, but you expect the rank ligand to be high because your resorption is more because there is estrogen deficiency. So I think at that point of time, we will now be starting with the basic quiz. And for that, we have joined with our different colleagues from around the globe, and we will introduce them one by one before we start off with the quiz. So we have got Dr. Savar Agarwal. Dr. Savar, kindly unmute yourself and you can introduce yourself. We all know Dr. Savar is a senior pediatrician from Raipur, and he has been practicing for over 45 years. And he has been instrumental in setting up pediatrics in that region. And he is really very keen quizzer in that regards. He has been part of all three quizzes that we have at Dr. Savar.
Thank you, Dr. Anurag. It's a great pleasure to be part of this ongoing quiz program. And endocrine really fascinates me. And when I listen to you, you are a great motivator for that influence on me personally. And I really enjoy participating in the quiz. Thank you so much.
Thanks a lot, Dr. Savar. We have got Dr. Varsha Rai Lakhani, who is a pediatric endocrinologist in training and who is currently working as an assistant professor at NICH in Karachi. Dr. Varsha, kindly introduce yourself.
Hello,
to have you here.
Hello, dear Dr. Anurag and all my colleagues. I'm Dr. Varsha Rani, as introduced, and currently I'm practicing in Karachi, the largest tertiary care hospital in NICH, as assistant professor and pediatric medicine, and I'm also fellow trainee of pediatric endocrinology and diabetes.
Welcome, Dr. Varsha. We have got Dr. Anshika Mishra, who is working as a senior resident at KGMU in Lucknow. So, Dr. Anshika, kindly unmute yourself and introduce yourself.
A very good evening to everyone. I am a senior resident working in King George Medical University, Lucknow, and I'd like to thank Anurag sir for giving me this opportunity. I am highly obliged, sir. Thank you.
Thank you, Dr. Anshika. We have got Dr. Sharan Thangaraju, who is working as a senior resident at AIIMS, New Delhi. He has joined us. Dr. Sharan, welcome to the program. Kindly introduce yourself.
Thank you so much, sir. I just finished my MD here in AIIMS in 2023, and I'm actually very much interested in the field and hoping to do a DM residency at some point. So thank you for having me, sir.
Thank you, Dr. Sharan. We have got Dr. Vasanta. I think she is inverted or something. Dr. Vasanta is a senior pediatrician from Kolkata. It's very, you are looking upside down. So, but anyway, you introduce yourself. You are muted. You are muted. उनके कैमरे को आई थिंक वो करना होगा. Dr. Vasanta, you are muted. Mute, unmute. She is actually yes, Dr. Vasanta.
Actually, I'm sorry for my inverted image, but I don't know.
So no worries. That is fine with us. I think the sixth participant we don't have. Dr. Al Hassan is not joined yet now, I think. So we were waiting for Dr. Al Hassan to join and
mirror, mirror ta bond korle mone hoye jabe.
So I think she is not there. So anyhow, we'll start the quiz right away. We won't spend any point.
नहीं उसमें टिक मार्क किया था
Uh,
बंद किया ना हाँ
So we will request all the participants to be muted. So I'll mute basically, but whenever the question comes, you can unmute yourself and open your camera at that point of time, so that we'll put it in that form from that regards. So we'll be starting our basic quiz right away. We have got 5 people now, so we'll be the 5 participants. Somehow Dr. Al Hassan from Saudi Arabia could not join in, I believe, for some reason or the other. So we have got these participants. We've got Dr. Savar Agarwal from Raipur, Dr. Vasanta, Dr. Al Hassan is not there, Dr. Varsha, Dr. Sharan, and Dr. Anshika. So we will have overall 5 rounds, and we will go from Dr. Savar to Dr. Anshika. Second round will go to the opposite direction. There will be 4 such rounds, and then the 5th round will be on Badar. So we'll talk about how the Badar round will work from that regard. So for this, the first prize is the complimentary access to our basic pediatric and online course. And then the second prize is about our adolescent endocrinology course. And then we've got various modules and apps which will be there for all the finalists. There are also very interesting questions there for audience. Dr. Vibha is monitoring for the audience response. And those who give the maximum correct response will be given some awards as well. So there are 5 rounds, 4 direct and 1 Badar round. 10 marks for direct, 5 marks for pass. So if something passes to the other, so we request all the audience here and all the participants to keep silent. We'll ask at the end if their answer doesn't come up from there. 15 seconds to answer. Maybe 15 seconds is more. We can give 10 seconds, usually should be good enough. We'll see. That will be up to me. And finally, my decision will be final. So there's no argument there because we don't want to refer to anything else. So it will be the final from here as well. These are all case-based scenarios. There is nothing theoretical about them, so don't worry about it. It's all practical. So we'll start with the first round, and we will be starting with, you can give me the slip. Dr. Savar, ek slip aise do diye. So the first question will go to Dr. Savar Agarwal. And the question is, we have a 10-year-old boy with seizures who has an ionic calcium level which is low, and this is the finding on CT scan. The specific question is, which feature on examination will clinch the diagnosis? So, Dr. Savar?
We will have to look for evidence of pseudo-hypoparathyroidism in this child. Okay. And brachycephaly could be one of the clinical findings, or subcutaneous nodules could be another clinical finding, which will help us clear.
Yes, absolutely right. So 10 marks, I think. Very good start again from Dr. Savar. So this is classically a case of pseudo-hypoparathyroidism. So we're looking at brachymetacarpia, or we are looking at subcutaneous nodules. This is PHP. So 10 marks to Dr. Savar. Dr. Vasanta, the next question to her. Hopefully she is now in a erect overall image. 2-year-old girl with failure to thrive in rickets. We can see very significant rickets, and we can see even fractures which are there. Now, she was very short. She was failing to thrive. She has a very high level of alkaline phosphatase, low level of phosphorus. There is metabolic acidosis, which is mild, and the urine pH is 5. So we have got all the picture, rickets with a low phosphorus, metabolic acidosis, and a urine pH, which is 5. The question is, we just saw at something and made the diagnosis immediately. So what is the clinical pointer which led to the immediate diagnosis? Like in last case, it was brachymetacarpia. Here was something else which will give the diagnosis immediately. Dr. Vasanta? And Dr. Vasanta is there? Dr. Vasanta, unmute. Dr. Vasanta.
Yeah, I have unmuted.
Yes, Dr. Vasanta. Yeah. So what do you think is this case?
Actually, alkaline phosphatase is a bit high.
So Vasanta?
Healing rickets or what? I don't know.
Okay, so this is rickets.
Rickets, so definitely, but whether there is a healing line.
Acidosis. You have got metabolic acidosis. The clue is further there. So one clinical clue which gives you the diagnosis. So if you have any particular answer for that? If not, we will move forward to the next participant, Dr. Varsha. Dr.
Um,
Varsha?
This is a case of proximal RTA, and
Yes.
clinical finding can be eye examination, cystinosis. This
Sure.
could
Very
be
good.
clinical
Very good.
finding.
So it's a very good answer. So this is a case of proximal RTA, and we are looking at cystinosis and eye examination, as you said. So 5 marks would be there for Dr. Varsha. You are recording on that. Now, the next direct question is also to Dr. Varsha. We have a 15-day-old girl with failure to thrive. Birth weight was 1800 and current weight is 1600 grams. Blood glucose is 425. So very high sugar. Failure to thrive, neonatal, sugars are high, non-ketotic and dehydrated clinically. She is not affording genetic study, but there is something which we found on examination which suggested that this could be a transient form rather than a permanent form of diabetes. So what?
Clinical findings which could indicate could be omphalocele and ear creases can be the finding which can
Very
lead us
good,
to
very good. Yeah. So this was a very good response again. So 10 marks to Dr. Varsha. Umbilical hernia, omphalocele, ear creases. So these are all indicators that we are dealing with a scenario of a sort of a imprinting disorder like Prader-Willi, like Beckwith-Wiesmann, and this will be a transient one. So again, excellent response. So you will get another 10 marks there. Next question is for Dr. Sharan. 2-year-old boy with morning hypoglycemia. Blood sugar is 24, ketone is positive 3.4, cortisol level was very low. So you have ketotic hypoglycemia with low cortisol and hyponatremia. Your question is examination of the eyes gave you the diagnosis. These are all clear-cut diagnostic questions. What was there in the eye which gave you the diagnosis, or what was not there on the eyes which gave the diagnosis? Dr. Sharan.
Hypertension, not sure, sir.
Okay, so low cortisol, hyponatremia. Anything you want to pass in? Then we'll move forward to Dr. Anshika. Dr. Anshika?
Yes, sir.
Yeah, you
So,
want to attend? Yeah.
So this is a case of pan-hypopituitarism. Maybe,
Okay.
sir, we can, in case of Bardet Moon Beetle syndrome, like retinal dystrophy or something
No,
like
no.
that.
So, no, we are looking for something else. We'll move
Is
forward.
it septic dysplasia?
Doctor, no. Dr. Sharan, your time is over. Dr. Samar? A child with ketotic hypoglycemia and low cortisol. Dr. Samar, are you there?
This looks like a cortisol deficiency.
Yes, yes.
Congenita, adrenohyperplasia congenita.
Dr. Vasanta, you will be next. Dr. Samar, you can, what examination of way eye cleans the diagnosis? You have to go for what are you looking in the eye? Dr. Samar? Yes?
Alecremia.
Yes, very good. So you are looking with the possibility of a triple A syndrome. So in this scenario, you can have alecremia, which will be there. So 5 marks to Dr. Savar. I think that was a good answer. It was slightly difficult question. I think the last question in this round would be for Dr. Anshika. So this is a 16-year-old boy with delayed puberty and height is 172. So this boy is not short. Penile length is 3 centimeters. Testicular volume is 1 ml. Pubic hair is stage 3. LH is less than 0.1 and testosterone is undetectable. So there is a hypogonadotropic hypogonadism. Now, what pointer on examination will give you the diagnosis immediately? So these are all about reaching diagnosis immediately.
So defect in smell, anosmia.
Anosmia, very good. Anything on examination, anything else other than anosmia? So what is the diagnosis? If there is anosmia, it will be?
Kalman syndrome.
Kalman. So we'll give you that. So we were looking at thin kinesia, anosmia.
Thin kinesia, yes, sir.
So
Anosmia.
that's fine. So that's a correct answer. So 10 marks for Dr. Anshika at that. So we are at the end of first round. What is the score? Yeah.
So the score at the end of the first round is Savar sir and Varsha ma'am at 15 marks each and Dr. Anshika at 10.
Okay, very good. So we will now have the audience question, which will be there. So this was the sixth question, which we'll skip. The audience question is 2-year-old girl with vaginal bleeding, and we will request the audience here to speak a bit later before we get all the and the chat option. So all the audience can answer in the chat option or the Q&A. 2-year-old girl with vaginal bleeding, breast stage 2, pubic hair 1, low LH, FSH is 1.2, estradiol is very high. Finding on X-ray, which will give you the diagnosis. So let's see how many people answer on the chat option. When we get the answer, the first one you can tell us, Vibha. So finding on X-ray in a girl with peripheral precocious puberty, yeah? Who have answered? Yes. So fibrous dysplasia, Dr. Aniket Kambojkar, and he is followed by Sayan Banerjee, fibrous dysplasia. So yes, Sayan, it is fibrous dysplasia. So you won't get any prizes for that. Dr. Aniket, we can note Dr. Aniket's name. So this is clearly McCune-Albright syndrome. So this is clearly, you have to look at fibrous dysplasia, which is there in this scenario. Now we will move to the second round. So score already is 15 marks for Dr. Savar, 15 marks to Dr. Varsha, and 10 marks to Dr. Anshika. Dr. Sharan and Dr. Vasanta are yet to open their accounts. So don't worry, even the last round you can make a huge difference because we will have huge marks which will be there on the buzzer round. The next round will go the reverse. It will go from Dr. Anshika onwards towards the other way. It is the plan to workup. So you have to plan. There'll be some questions which we have to tell what the workup should be. 1-month-old child with atypical genitalia, Prader 4, you can see here.
Sir, I'm not able. Yes, sir. Visible, sir.
Yeah. And there is no palpable gonad. Mullerian structure is present. And the child is 46XX. So there is no gonad and 46XX. So XXDSD, I think it's easy. 17 OHP is normal. DOC is normal. We took one history which gave the diagnosis. Just one history gave the diagnosis. So what are you thinking of in this girl, Dr. Anshika?
Sir, there is some maternal hyperandrogenism state,
Exactly.
maternal
So
intake
what are you, yes. So what are you
uh,
thinking of which diagnosis?
placental luteoma. In case
Okay, anything
for
else in which you have maternal virilization along with this DSD?
maternal virilization along aromatase
Yes. So
deficiency.
because the question was on history, so I'll give you the answer. But yes, both options are there. Luteoma is very unlikely, but maternal virilization, aromatase deficiency. So I think this was the right answer. Again, 10 marks to Dr. Anshika. So the next question is to Dr. Sharan, 3-year-old boy with hypoparathyroidism, abdominal pain, polyuria, and vomiting. Calcium is now very high. His calcium was never high. His calcium now is very high, 16. Calcium remained high
Excuse me,
despite...
sir.
Yes?
Sir, can I interrupt in between, sir?
Yeah,
Slides are not moving, I guess.
Is any other people able to view the slides?
Yeah.
It's working from the other side. Maybe your
Yeah,
connection.
Now it has changed, sir.
Okay. So there might be some issue in the connection. Don't worry, we take time to explain it. So a 3-year-old boy with hypoparathyroidism, abdominal pain, polyuria has hypercalcemia, which was persistent despite decreasing the dose of calcitriol. Which test will tell you what is the most likely cause?
So a child with hypoparathyroidism with a decreasing dose of calcitriol, first we need to suspect we need to look for any cortisol deficiency, sir. So we need to do an ATM.
Okay. So what association, which type of autoimmunity are you thinking we are dealing here?
APS type 1, sir.
Type 1. So this is absolutely right. 10 marks there to Dr. Sharan. This is APS1. You should get a cortisol level done in this scenario. Next direct question to Dr. Varsha. 7-year-old girl with early puberty. Breast stage 3, pubic hair stage 2. Bone age is 10 years. So bone age is advanced. LH is 1.2, FSH is 2.2, estradiol is although undetectable. So now the pediatrician has referred to us that this is a very unusual case. She has no estrogen, yet she has got so much breast development. So what do you think is wrong here, Dr. Varsha?
Estradiol is quite, sensitive test, and most of the laboratories denote to the adult
Yes.
range of estradiol reports, na. So
So-
this is a case of central precocious puberty,
Yes.
and these
So this estradiol level, most likely if you do not do via GCMS, you may miss it. So this is an immunoassay based result, and that's why the result was falsely low. So again, perfect answer, Dr. Varsha, 10 marks there. The next question is to Dr. Vasanta. 14-year-old boy with gynecomastia who has breast stage 2, testicular volume is 12 ml, so it's pubertal. LH is 1.8, FSH is normal, testosterone is 120, which is okay for this age. Prolactin is 120. MRI head is normal. So now in this boy with gynecomastia who has got normal gonadotropin and testosterone, high prolactin, normal MRI, what do you think should be done next, Dr. Vasanta here?
It might be drug induced, and we should take drug history.
Okay, that's there, but anything else? So if your prolactin is high, what do you expect the LH level to be? Should have gone low.
Yes.
So your prolactin is high, but your LH is not low. So this, then you can maybe think of it. Something else?
Yeah, it could have been, but for macro levels, it should have been more high.
For macro, so you can come back again. What exactly I'll give you one more chance. So what error you are thinking here?
Maybe we have to do dilution.
No, we have to go to the next one. The next one from here would be Dr. Savar. So Dr.
Could it
Savar,
be-
what do you think is happening here?
Should we do a pegylation prolactin level?
Yes, absolutely right. So this is a case of macroprolactin where you have no features, but your prolactin level is high. So here you should do
I told macro prolactin, but I
you
didn't
didn't,
tell
you said only
pegylation.
macro. You said only
Yeah.
macro and then you said dilutional. So that's
No,
why.
I wanted to tell macro prolactinemia, but dilution I should have told pegylation.
Yes.
That's the
So unfortunately, we will. It was a bit
no
late.
problem.
Yeah. So Dr. Savar will get 5 marks for the correct pass. And now we will have a so this was a macroprolactin and should have done a pegylation study. So now this is for Dr. Savar, 14-year-old boy with the weight gain. Height was 126 with myopathy and stria. Now ONDST was 250, which means after DEXA, the cortisol level was high. ACTH was very high. MRI was normal. So what would you like to do in this case now? Next test.
This could be an ACTH producing tumor extra.
Yes. So
Tumor.
ectopic tumor you are saying.
Yes.
So what will you do now? So you have got a high non-suppressed ONDST with this ACTH dependent, MRI normal. Next step.
We can I am exactly not getting the site from it is which will give us the clue for the ACTH production.
We will come back to you if there is no clear-cut answers. We will move to Dr. Anshika.
Sir, we will like to have a CCT abdomen.
CCT abdomen. Anything before that? I think we'll go for more specific one. Yeah,
Sir,
you've
we can
given
high dose dexamethasone suppression test.
we'll give another option to Dr. Sharan.
I had the same answer, sir. CCT chest and abdomen.
Okay, Dr. Varsha.
We can go to the inferior petrosal sinus sampling, which can denote the lesion.
Yes.
Where
So
it is coming.
IPSS will be the right way to go forward. So first you have to make sure that this is actually ectopic. So IPSS will give you the centralization is there or not. So I think this is the right answer. And other things will come, CT abdomen, chest, PET, and all those things will come later on. So I think this was a good answer on that. So I think we have done all the questions of this round as well. So high dose DEXA is a debatable one. The latest guidelines talk about IPSS directly in this scenario. Yeah, Dhwani?
At the end of the second round, we have Dr. Varsha at 30, Dr. Savar and Dr. Anshika at 20, and Dr. Sharan at 10 marks.
So nothing to worry. We've got 2 more rounds to go, and then we have got the excessive, we have got the other buzzer round as well, in which you can get 60 points right away. So before we go ahead on that, we will have, so this was IPSS, and this case we are skipping because already we have had that. So this is for the audience, 8-year-old boy with thyroid swelling, which is moving with tongue movement. What will be the diagnostic test which will give you the diagnosis? So anybody has answered other than Sayan? So diagnostic test for this child? Yeah. Any answers? So Dr. Nikhil is saying perchlorate. Anybody else here in the audience? Technetium scan, Dr. Aniket. So Dr. Aniket is saying the correct answer in this regard. So technetium scan, this is most likely a thyroglossal cyst. You should do a technetium scan, and then surgical intervention would be required from there. So we have already finished 2 rounds. We'll see if Dr. Ellison has joined or somehow. You have seen them? You can see. She's not there, no? Yeah, so somehow she is not there. So anyway, we will continue now with our round 3. This will again now start with Dr. Savar, and we will go in that direction. So Dr. Savar, this round is about mostly treatment. How will you plan treatment from here? You made the diagnosis. 1-year-old girl with dehydration, dovey skin, sodium is 167, urine osmolality is 900. So there is a lot of concentrated urine. She was given N/2 in 5% dextrose, with which she suddenly developed seizures. So she is being treated for hypernatremia and now developed seizures. So Dr. Savar, how will you treat her?
This child will need 3% saline to control the seizures in a dose of 4 to 5 ml per kilogram. To control. Yes.
So this is the right answer. So this is exactly, we discussed the previous case. When you have hyponatremia, rapid correction, you bring it down. Here you rise it up. So you need 3% saline. So 10 marks to Dr. Savar on that. Next question is to Dr. Vasanta. 2-year-old girl with precocious puberty. She has stage 3 breast and vaginal bleeding. LH, FSH is low. Estradiol is high. She has irregular cafe au lait spot, as against the previous case in which we said regular cafe au lait spot, has multiple bony defects. So I think the diagnosis is very clear. The question is, which is the most effective treatment for early puberty? Which drug is the most effective or most specific? I'll ask that question. So this is macunalalbride, which you already said that. But which will be the most effective treatment for this early puberty? So Dr. Vasanta?
Pass.
Pass. Dr. Varsha?
Anti-estrogen antagonist, the newer drug, fulvestrant, is a drug of choice.
Okay,
Other than that, letrozole and tamoxifen.
Yes. So we got the answer. So it's the specific treatment, which is the anti-estrogen fulvestrant. So I think that's the correct answer. So 5 marks to Dr. Varsha for this. Pass. Now this is a correct direct question to you. 12-year-old boy with polyuria, developmental delay, hyperphagia. So polyuria, developmental delay, hyperphagia, infantile hypotonia. I think you're coming towards the nearer question. And he also has diabetes now. Now, which treatment will improve body composition?
Growth hormone treatment.
Yes, so I think this was a straightforward question. I think this is Prader-Willi and this is growth hormone treatment. Again, right answer. So I think that is clear from there. Next question is for Dr. Sharan. 14-year-old girl with emaciated appearance, Fasting sugar is 320, 2R value is 566. HbA1c is very high, but there is no ketosis. So there is no ketosis, lean individual on very high dose of insulin. So what is the treatment of choice of this type of diabetes? Dr. Sharan.
Uncontrolled hyperglycemia, Norton decay.
A very lean individual, emaciated.
Maybe an insulin pump, sir.
Insulin pump. Okay, we'll move forward to
Or
the
sir,
next.
is it a type of lipodystrophy?
Okay, I'll give you the chance, last chance. Which treatment will you think of?
Treatment would be metleptin, recombinant leptin.
Okay. Okay. So this is lipodystrophy, and we will give the answer to you. You can use leptin, metryleptin as an option. So this is classical. Everywhere it was written over the case that this is a lipodystrophy. So 10 marks to Dr. Sharan. Last question of this round to Dr. Anshika. 15-day-old girl with dehydration and polyuria, hypercalcemia, and low phosphorus. PTH is high. Urinary calcium creatinine is not that high. Parental calcium is mildly high. So this is, obviously we know this is hyperparathyroidism. The question is which treatment or which drug can decrease the PTH? It specifically works on decreasing PTH level. Dr.
Cinacalcet.
Cinacalcet, absolutely right. So this was again a relatively straightforward question. So Cinacalcet, again 10 marks to Dr. Anshika. So by the time we get the score, we will have this question which will come for the audience. You can tabulate by that time, Dr. Dhwani. So the audience question is, 3-year-old boy with 21 hydroxylase deficiency on a high dose of hydrocot, 0.05 of fludrocot, 17 OHP of 30, which test would help you improve your management? So for the audience. So you're being telecast as well. So anybody answered? Somebody has written renin? Yeah, who? Yes, so Dr. Deepak from Nepal has mentioned renin. So plasma renin activity, renin content, because your mineralocorticoid seems to be less. If your mineralocorticoid is less, your hydrocort requirement goes up. So this case, renin will basically be the done. What is the score now, Dhwani?
At the end of third round, we have Dr. Varsha at 45 points, Dr. Anshika and Dr. Savar at 30 each, and Dr. Sharan at 20.
Okay, thank you, Dhwani. So we have got the fourth round which is coming up, and we'll go on the other way round from Dr. Anshika, and then we will go back from Dr. Sharan and that way forward. So this is spot the diagnosis. There is no pass. So there will be no pass with this one. Only you can answer your direct answer because the diagnosis will be evident. 12-year-old girl with severe backache. These are the findings on the imaging, and this is the finding on examination. Dr. Anshika, you have to tell us what is the likely gene defect in this case.
Sir, can you please elaborate the findings on the MRI?
Okay, so MRI is showing multiple fractures which are there in the lumbar area. There is collapse fractures which are there. And then along with she came to us with severe backache, and there are these fractures, and something was done on the eye examination, and then immediately the diagnosis was there.
So, osteogenesis imperfecta, the gene collagen,
Yeah, collagen.
col1.
Okay, fine.
A.
Good. So we'll give you, it's type 1 OI, call A1. So this is the most milder form of OI, which is there. So there is the blue sclera, which is very clear, and there are pathological fractures. And this child actually underwent biopsies, bone marrow biopsy and everything before they send her to us. So this is very unfortunate scenario there. Next case is to Dr. Sharan, 24-day neonate. These are the X-ray findings which are there. Calcium is 12.4, phosphorus is high. What is the diagnostic test? So you are able to see the X-rays clearly?
So the slide hasn't, yes, I could see it now.
Yeah, so this child presented with the high calcium, high phosphorus, and this X-ray. And you can look at the ribs maybe, and you can look at the long bones. Very, very characteristic picture on the X-ray. Simple test gave you the diagnosis.
We can, sir, this could be possibly Jansen's
Jansen's phosphorus levels will be
low in there.
so
So
high
vitamin
phosphorus,
D
high calcium.
Vitamin D toxicity.
No, we will move forward. We'll now go to Dr. Varsh. Acha, this is no pass actually. Sorry. So this is a case of anybody in the audience here. So this is hypophosphatasia. You can see very, very demineralized bones. Alkaline phosphatase level will give you the answer. So this is hypophosphatasia. So we will now move forward to the next question. This is direct question to Dr. Varsha. A 17-year-old girl with amenorrhea for 3 months. She has stage 4 breast development, stage 4 pubic hair development. LH is 0, FSH is 0, prolactin is 500, TSH is 4.4. What is your diagnosis? Or what will you like to do here? And yeah, one more report, estradiol is 400. So 17-year-old girl with 3 months amenorrhea, low LH, FSH, prolactin is very high, estradiol is very high. Dr. Varsha?
MRI brain, should we go for it?
Why is the estrogen very high?
This could be because of ovarian cyst, ultrasound ovaries.
But then why prolactin is high? So this is a trick question. I think one last chance.
No clue.
Okay, so this is it's a bit confusing, but it's actually a
Pregnancy.
most common cause of secondary amenorrhea with galactorrhea and high prolactinemia is pregnancy. So whenever you have these sort of unusual question, high prolactin, always get a HCG done. So this was a difficult one, but it was an interesting one which we use. So I think we'll stop on that. The next, so this was basically HCG was very high in this case. Then we have the next question to Dr. Vasanta. 14-year-old girl with hyperglycemia. Fasting sugar is 130. 2R value is 220. HbA1c is high. There is no ketosis, nothing. There was a history of neonatal hypoglycemia. And there was family history of diabetes in the family. What drug, and I'm saying drug, is the most effective therapy of this type of diabetes?
Sulfonylurea?
Yes. And what are the type of diabetes you're looking at? So this is, of course, a monogenic diabetes, and there is neonatal hypoglycemia. So we're looking at transcription factor, MODIs, HNF, 1 alpha, 4 alpha. So sulfonylurea would be the correct therapy. So we will, or GLP-1 receptor analog, we'll give 10 marks to Dr. Vasanta there. So a good answer on that. Last question for Dr. Savar. 14-year-old girl with rash and joint pain. Calcium is 13.2, phosphorus is 5.2. So calcium is high, PTH is undetectable, vitamin D is normal, calcitriol is on the higher side. So the question is, which test will give you the diagnosis? 14-year-old girl with rash and joint pain, arthritis and rash, nodules are also there, hypercalcemia, undetectable PTH, vitamin D low, calcitriol high.
This looks like a sarcoidosis.
Exactly. So which test?
So we can do the S test.
Yes. Okay. Very good. So the answer is perfect from Dr. Savar. So 10 marks again. So before we go ahead with the scores, we will go for the audience question, I think, for this round. So the audience question here is 11-year-old boy with refractory rickets, low phosphorus, calcium is 9.4, PTH is 12. Most important test before you start the treatment. So anybody has answered? So this is hypophosphatemic rickets, urine phosphate. Anybody else?
Creatinine. Creatinine.
So anybody in the audience? Urine calcium and creatinine to rule out the hypercalciuric variant of hypophosphatemic rickets. So this was for the audience. And now we will go for the scores. Yeah. So the gap is only 35 and you can score 60 points directly in this one. So anybody can win and anybody can lose. So these are the slog overs which are there. So this will be the buzzer round. Now this will be a fastest finger first. So what we will do in this case, you have to be careful about the rules, is that basically I'll write a N once all the answers are there in the chat. After that, the one who is sure of the answer has to write Y. So they want to give the answer and Vibha is there and Alapan is there who will pick up who is the first one to write the buzzer and then he will answer the question. I'll stop the question there. I'll not ask the question any further. So you need to be confident as to what the question is. You just don't jump in between. Now the point is, if you have to answer immediately, you can't take time for answering and there will be no pass. Plus 10 for correct and minus 10 for wrong answer. So you can go 0 also here. So minus 60, everybody can go to 0 as well. So I think everybody is clear about this.
Can you explain once more, please?
Yes. So what I'll do is that now all of you can have a look at the chat.
Yeah.
So you have opened the chat, everybody. So I will write N, which means now the question has been reset. Now all of you can write Y and
okay.
have they answered?
No, we lost the connection. We didn't hear you.
My voice
Yes,
is not visible.
We didn't hear the question at all.
So the slides are also not moving. The audio and video is not there, sir.
So I will write N here. Now all of you can write Y. Now we've got the answers. Okay.
Your connection is unstable, Dr. Your connection is unstable. In between it goes off.
কিছু শোনা যাচ্ছে না, এখন শোনা যাচ্ছে না, তখন শোনা যাচ্ছিল, এখন যে কি হচ্ছে জানি না।
শোনা যাচ্ছে না কিছু? ঠিক আছে, আমি কথা বলছি।
হ্যাঁ, এখন কি কিছু বলছে না? কিছু তো মুখ করা নেই।
Savar, can you hear me?
এবার আমরা এটাতে লিখবো তো?
Yeah, in between the connection goes off.
হ্যাঁ, মাঝে মাঝে চলে যায়।
Yeah, there was some confusion there, but now I think it is there. So all of you please write a Y and we'll start off the question then. Yeah, just once more. So I've got from Dr. Savar, Dr. Varsha, Dr. Sharan, Dr. Anshika, and from Dr. Vasanta. Okay. So I think we'll start off with the, so now everybody is clear. I will put the end here.
কোশ্চেনটা কোথায় আসবে তাহলে? হ্যাঁ, where will the question come?
So I will ask the question, I'll show the question and then you have to start the, so now I have reset that. I'll start the questions. So we have the first question coming up now. You are seeing the screen?
Yeah.
Everybody seeing the screen? Okay.
Yes.
So everybody be ready with your buzzer. We will project the question right away. I'll speak also. As soon as you think you know the answer, you write a Y. Vibhai will tell me immediately. First question is 2-month-old boy with failure to thrive. Blood sugar is 320. There are multiple skin infections, diarrhea. The child is GAD positive. What thing, treatment, intervention should be avoided in this child? So Dr. Varsha?
This is case of IPEX.
Yes. So what should be avoided?
That is
The question is what
metformin
should be
should
avoided?
be
Yes, yes.
metformin should be avoided.
No, I'll give you one more option. I'm thinking of anything that you do normally in a child which should not be done in this child. So it is IPEX, it's correct. But something you do in every child, you won't do in this child.
Insulin, we would
No,
start the
insulin is required.
required.
So the answer for this is actually
Vaccination.
immunization or vaccination.
Oh.
So unfortunately, you have to look at the full answer question before you write that. So it was immunization. It will be -10. So be careful with the next one as well. So the next question is coming and I'll reset that. I'll reset the chat option. So I have put N, and as soon as you are sure, you can write the option on the chat. So the next question is 16-year-old girl with tremor, tachycardia and weight loss, high F3/4, low TSH, scan showed reduced uptake and thyroglobulin is undetectable. What is the cause? So thyrotoxicosis, reduced uptake, thyroglobulin undetectable. Anybody?
Thyroid adenoma.
Thyroid adenoma. Thyroglobulin will not be undetectable in this case. Anybody in the audience here? This is exogenous thyroid, thyrotoxicosis fictitia, because you have got high thyroid, scan is not, body is not producing, and thyroglobulin is undetectable. So again, so this is intake of thyroid hormone. So factitious intake of thyroid hormone. So again, the answer will be -10 to Dr. Savar. So we are reset. So this round I said is always dangerous. So you have to be careful about this round. So now I have reset again. And the third question is coming. 11-year-old girl with recurrent fracture, and she has got fractures, she has got severe bony disease, she has myopathy, hypokalemia, phosphorus is low, metabolic acidosis, nephrocalcinosis, everything is there. So I think you know the diagnosis. My question is, once you give bicarbonate, what will happen? Dr. Anshika, what will happen to potassium on giving bicarbonate?
Sir, it will decrease, sir.
It will decrease. So what is the diagnosis here? This
The
is which type of RTA?
sir,
PTA.
This is,
proximal RTA, sir, and the
but there is nephrocalcinosis, the urine pH is alkalines. This is distal RTA actually.
yes, sir, distal RTA, yes, sir, but
And distal RTA, the potassium improves with treatment.
okay, yes, sir.
So this was a catch. So again, -10. So somehow this buzzer business is going very, very negative. So don't worry. Still 3 questions, 30 marks to be scored off. So don't worry. We will have the final score before the last 2 questions. So next question, be ready with the score. I'll reset the chat again. So now the 4th question, which is coming here, is 12-year-old girl with growth failure, height is less. Everybody knows the diagnosis, brachymetacarpia, webbing. The question is most specific cardiac anomaly. Most specific. Dr. Savar?
Coarctation of aorta.
Coarctation.
When I say most specific, I am basically asking
Partial
about,
anomalous pulmonary venous return.
yes. So the answer will be PA-PVR because the risk of having this will be much higher. So there is no pass. So they will again be -10 to Dr. Savar. So this was the most specific, was a specific question. So we have now got 2 more questions to go and Dhwani will come up with the scores.
Once again, couldn't hear you.
We have Dr. Varsha at 35, Dr. Anshika at 30, Dr. Savar and Dr. Sharan at 20 each, and Dr. Varsha at 10.
So still there are 2 questions left and still anybody can at least get 1-2 position, everybody can get. So it's an open quiz now. 2 more questions to go. So play your ball appropriately. Don't try to overhit or underhit also. So I think now we will move forward to the second last question. I'll reset the chat. The 5th question is now 5-year-old girl with abdominal pain and acidotic breathing. Blood sugar was very high, so she had decay, very severe decay. And then she developed leg pain, oliguria, red colored urine during treatment. What preventive measure should be done? Dr. Varsha, what could have prevented this?
Phosphorus can be added in
Okay,
the.
yes. So if we had given phosphorus, we could have prevented this rhabdomyolysis. This is rhabdomyolysis. So I think this is a first answer which was right on the buzzer. Plus 10 to Dr. Varsha. So I think just before that, you can give the final. Any further standing? The last question.
Yes, लिखने को बोला था.
We have Dr. Varsha at 45, Dr. Savar and Dr. Sharan at 20, Dr. Anshika at 30, Dr. Vasanta at 10.
So the second position is up for grabs at the moment. So we have got the last question coming up. So I'll reset it. So I'll reset this. And the last question which is coming up here is 28-year-old girl, pregnant lady with SLE. Anti-Rho, anti-La antibody positive, fetal heart block, was advised steroid treatment. Which preparation will you recommend?
Dexamethasone. Dexamethasone. Yes, dexamethasone.
So Dr. Vasanta has said even before that. So what will that make Dr. Vasanta to be 20? So we'll give that to Dr. Vasanta, but you should have given it via this thing. So what are the final standings? So I think this was a very interesting quiz. And Dhwani, you can announce the final standings then.
So at the end of our quiz, we have Dr. Savar, Dr. Vasanta, and Dr. Sharan, each at 20 marks.
20 क्यों? पहले का 10 था. पहले का 10 था.
ये 10 मिलने के बाद आपका 20 है.
We have Dr. Anshika at the second position at 30 points. And the winner of the quiz is Dr. Varsha at 45 points.
Okay, very nice.
So I think congratulations to all of you. And it was a wonderful, very interesting program. All of us enjoyed here. We'll have quick words from all of you before we move to the advanced quiz. So Dr. Varsha.
Yes, sir. I really enjoyed this whole scenario, but this buzzer round was very dangerous.
Yes, so you stick. Finally, you got the right answers, I think, in the
Yes,
buzzer.
finally, exactly.
Dr. Anshika.
Yes, sir, this was very nice. I enjoy playing it and looking forward to more such sessions, sir, with you. Thank you, sir.
Okay, thank you, Dr. Anshika. Dr. Sharan.
Thank you so much, sir. I actually got to learn a lot from this session. Thank you so much.
Thank you. Dr. Savar, you are the senior most and your experience.
Yeah, I think I should have learned from my previous experience. And the previous experience also I lost in the buzzer round.
Yes.
So sometimes it's better not to answer in the buzzer round and be the winner.
Yes, that's true. And Dr. Vasanta, I think your experience.
I think it will take 1 year to become erectomage. Let me be able.
But even inverted, you got 20. So that was a good one. So I think that's
more
very
blood,
good
more,
for the.
More blood flow to the brain.
Yes, yes. So I think that was very good. Now we will move forward towards the advanced quiz, which is going to be at a slightly different, it's mainly for the endocrinology level quiz, which is going to be there. And we will start off with the
ठीक है, अभी क्या करें? या वहाँ चले जाते हैं, यहाँ पर बैठे हैं।
Dr. Vasanta, you can come also now. Your
We can go to the room.
yeah,
Okay.
yeah.
Thank you.
Thank you.
Yeah.
So we will be starting with the advanced quiz now, and we hope all the participants are there for the advanced quiz.
Yeah, let's go.
Dr. Guru Prasad, Dr. Arun, George, Dr. Nanda, Dr. Pooja, and Dr. Rajib. I think all of you are there. Dr. Priyanka is not there. Okay. So the advanced quiz will basically be the same quiz was there, and based upon that, the one who were in the endocrinology were taking part in this quiz. So while Dr. Priyanka is joining, we will like to introduce our different part as far as the quiz is concerned. So we are joined by Dr. Guru Prasad Udupi, who is a endocrinologist from Bangalore and who is doing a fellowship in pediatric endocrinology from MedEClasses. Dr. Guru Prasad. You are muted. You are muted, Dr. Guru Prasad.
Hello, sir. Good evening. And I'm very much thankful for your kind mentorship and for these kind of sessions.
Thank you, Dr. Guru Prasad. Dr. Arun George is doing DM at in pediatric endocrinology from Postgraduate Institute of Chandigarh, and he has been part of our quiz. I think this is the third time he is being part of it. So, Dr. Arun.
Good evening, sir. It is my pleasure to attend your quiz. Every year I learn a lot of new things from your quiz. So thank you very much for this opportunity, sir.
Great to have you back. We have Dr. Pamali Nanda, who is doing her DM in pediatric endocrinology from PGI Chandigarh. Dr. Pamali, kindly introduce yourself.
Right. So, good evening. So I'm Dr. Pamati. I'm doing my DM. Actually, I'm about to complete my DM residency at PGI. So I'm looking forward to the quiz and really excited for this opportunity.
Yes, great. We have got Dr. Pooja Tiwari, who is doing her DM from the Guwahati Medical College in Guwahati. Dr. Pooja, you are muted and your video is not on. Please switch it on. Dr. Pooja Tiwari. So you can call her Dr. Pooja. We have got Dr. Rajib Das, who is assistant professor in Burdwan Medical College in Pediatrics, and he's also part of our MedEClasses fellowship program. Dr. Rajib.
Good evening, sir. I am privileged to be here to join the quiz. Thank you.
Thank you, Dr. Rajib. And we are waiting for a couple more people. Dr. Priyanka. And Dr. Pooja. But panelist may have upgraded her.
She is not able to join. She is joined, but her video and she is not able to unmute herself.
Why?
Pooja.
Pooja. So Dr. Priyanka is there.
Yes, sir.
Dr. Priyanka is a pediatrician at Monilek Hospital in Jaipur, and she's also part of our fellowship program. So Dr. Priyanka, kindly introduce yourself.
Sir, I'm practicing at Jaipur Monilek Hospital, and I'm part of this program from last 3 years. And I'm also giving this my exam this time, fellowship exam.
Okay. So thank you, Dr. Priyanka. Dr. Pooja, you can try to log out and log in again. Because we're just waiting for Dr. Pooja. I think everybody else is joined already. So before Dr. Pooja joins in, we'll just explain the rules. They are pretty similar to what the basic quiz rules were. So we will have basically got there will be 5 rounds. 4 rounds will be the one in which you have to answer, and the 5th round will be on buzzer. and you will have direct and pass in that regard. So you can just maybe connect once more to Dr. Pooja if she is able to join. So, okay. And Dr. Pooja, can you hear us now? So we will keep Dr. Pooja as the last participant for the first round and see how it goes from there. We'll start off with the first round then. Okay, so हाँ क्या हो रहा है? Okay, so we'll start off with the quiz. I think if Dr. Pooja is able to join, she can join as the last one for this one. A coffee. So we'll start with the first round, which is a spot the diagnosis round. The rules are there will be 4 direct and 1 buzzer round. 10 marks for direct, 5 for pass. 15 seconds to answer, only one answer is to be given, and quiz master decision is final again. So same rules are there. So we'll start with the first round. Spot the diagnosis. We'll start off with Dr. Arun.
So you are not audible, sir.
Dr. Arun.
So there was a problem with the connection. You are not audible in.
Dr.
Hello.
Arun, did you get the question?
No, sir.
I'll put it again then. Yeah, you can see the screen now.
Hello.
Yeah, hello.
Hello. Good evening, sir. Am I audible, sir?
Yeah, you audible. Dr. Pooja now? Yeah.
Yes, sir. Yes, sir.
Okay. So
I'm
you are audible. Is your mic? You can also try to switch on the video. If not, that's fine with us. Yeah.
yes, sir. I will try, sir.
Okay, no worries. So we'll start off with the first question to Dr. Arun. 11-month-old girl with failure to thrive, birth weight of 2500 grams. Blood sugar is high, non-ketotic, GAD negative. Consanguinity is there in the family. Gene implicated in this based upon this X-ray, and what are the life-threatening complication you may find in this child?
So this is Walcott-Rallison syndrome.
Okay.
So the
gene?
gene, the life-threatening complication is liver failure, sir.
Okay, sure. And just a final time, I'm nagging you, the gene once more.
Gene, I'm not able to recollect, sir.
Okay. No worries. So we'll give you the 10 marks. So this is the correct answer. This is Walcott-Rallison because there is family history of consanguinity. There are skeletal abnormalities which are there. So this is basically a EIF2AK3, which is basically Walcott-Rallison and hepatic dysfunction. So 10 marks to Dr. Arun for the correct answer. The next question is to Dr. Priyanka. 2-week-old girl with refractory hypoglycemia. Birth weight is 4 kilograms. GIR is very, very high, non-ketotic. Insulin was high and cortisol was very high. So this was a classical case of what we thought this is hyperinsulinism, and the diagnosis was made. But suddenly when she was in the ICU, the fluid was suddenly stopped and she developed severe hypoglycemia and now the child became ketotic. So this is an interesting scenario of how a non-ketotic became ketotic. So the question is, which gene can explain these findings? Hyperinsulinism with ketosis, while initially there was no ketosis. So Dr. Priyanka?
Sir, pass.
Okay, pass. Then it goes to Dr. Guru Prasad.
Pass.
Okay, Dr. Rajiv.
Can it be elementary hyperinsulinism types?
No. We'll pass it forward to the next one, Dr. Pamali Nanda.
Sir, this could be GCK or glucokinase mutation.
Okay, GCK mutation activating or inactivating?
Activating mutation in GCK.
Okay, and how do you explain this phenomena?
Like glucokinase mutations, basically if there is activating mutation, then the ATP cycle, like the glucose entering into the cells and the increased production of
That's
ATP.
fine, but why is there ketosis now, while it was not there earlier?
The exact mechanism.
Okay, so it is just like the opposite of GCK deficiency, wherein you will have high sugars to begin with, but they will not go very high. It will be taken off because it's a reset axis. Similarly, here you will have no ketone till a level, but you develop severe hypoglycemia, you will then develop ketosis. But anyway, perfect answer. GCK excess will be the scenario. So 5 marks to Dr. Nanda at that. Dr. Pooja, the next question is for you.
Yes, sir.
Oh, sorry. This next question is for Dr. Guru Prasad.
Yes.
So, Dr. Guru Prasad, the next question is to you. 16-year-old boy with testicular volume 1 ml, SPL of 3.5 centimeters, so micropenis, pubic hair 2, LH is low, inhibin B is 20. Testosterone was given 100 milligram and then 250 milligrams. On follow-up, testicular volume became 12 ml after 2 years. So after injection, the testicular volume increased. Which genetic cause can cause this phenomena? So there is hypogonadotropic hypogonadism, but the testicular volume increased after testosterone.
So Cal1?
Cal1 usually is a permanent one. So we'll move forward to Dr. Rajiv. Dr. Rajiv?
Yes, sir. So Anos, one mutation.
No, Dr. Nanda. Dr. Pamali?
This is a reversible hypogonadotropic hypogonadism.
Yes.
So could be TAC-R defect, TAC3R.
Okay. Very good. Very good. So full marks again, 5 marks for the pass answer. Dr. Pamali, very nice answer. So this is a reversible hypogonadotropic hypogonadism. TAC3 receptor is usually the most common cause. Fourth question is to Dr. Rajib directly. 16-year-old girl with delayed puberty. She has no breast development, stage 3 development, height is not short, LH, FSH, everything is low, estradiol is low, so hypogonadotropic hypogonadism. MRI shows a hypoplastic olfactory bulb. There is deafness and there is cleft lip. So I think now the diagnosis is clear. What is the genetic basis of this disease? Dr. Rajib?
Olfactory. A61. No, sir. It is.
Okay, not H6-1. Yeah, we'll move forward. Dr. Pamali?
It looks like Kalman syndrome.
Kalman syndrome, but there is something else as well. So we'll move forward next. Dr. Pooja?
FGF, FGFR, FGF3.
FGFR, okay, but you can't explain deafness and cleft lip with that. Dr. Arun?
So this is probably charge syndrome, CHD7 mutation. Charge syndrome, sir, CHD7 mutation.
Perfect. Absolutely right answer. So it also has anosmia and other things, but deafness, cleft lip, charge syndrome will become important from that perspective to really look at in that regard. So this is again correct 5 marks to Dr. Arun for this answer. The next question directly is to Dr. Pamali, I think. Yeah, 3-year-old boy with polyuria. Urine output is very high, 8 ml per kg per hour. Osmolality is low. Post water deprivation, it remained low, and after vasopressin, it increased. So this is central DI. I think the diagnosis I don't want to confuse. MRI is normal. There is no anterior pituitary defect. Now, interestingly, there was a genetic diagnosis which came up. Which cause do you think of could cause this disease, and why was the onset late if it is a genetic disease? So central DI, late onset. Dr. Pamali?
Yes, sir. I'm not sure.
Okay, so we'll move forward. Dr. Pooja?
Wolfram syndrome, sir.
Wolfram syndrome, usually the DI doesn't happen at 3 years, it happens much later, and they will have other manifestations. Again, Dr. Arun?
So this is central DI due to a genetic cause. That should be most likely neurophysin gene defect. The cause for delayed is this is like based on dominant negative. So only when the it needs a second hit. It needs two hit hypothesis. So second hit only.
Absolutely right. So this is a 2-hit. First you have misfolding, and then those cells get damaged. So this is a 2-hit model. Again, 5 marks to Dr. Arun for the correct answer. The direct question now, basically here, is now for Dr. Pooja. 6-year-old boy with failure to thrive. Developmental delay, coarse facies, FT4 is low, TSH is 3, normal GH, cortisol and MRI. Testicular volume is 10 ml. So 6-year-old boy who comes to us with mild developmental delay and coarse facies, he is short, he has low FT4, normal TSH, testicular volume is 10 ml. Pubic hair is 1. So what is the genetic basis here?
IGSF1 mutation.
Absolutely right. So again, 10 marks I think there for Dr. Pooja. So while Dr. Dhwani is collating the scores, we will take the audience question from there. 14-year-old girl with tall stature, height is 173, arachnodactyly, upward lens dislocation, pectus carinatum. Which acute emergency is likely? So maybe from the audience, anybody is writing? Yeah. Aortic rupture, but this is the upward dislocation, not downward. So homocystinuria, thrombosis can happen. So this was a trick question. So it is actually similar to Marfan, but it is slightly different. So aortic dissection. Yeah. So everybody was right. Yeah. Yeah, you're saying something? Marfan, yeah. So this is aortic dissection. So I think after the first round, what is the score? Okay, thanks, Dhwani. We will move forward to the next round, which is the imaging round, and we'll start with Dr. Pooja in the reverse order. So Dr. Pooja, 12-year-old girl with recent onset polyuria, urinary osmolality was low, post deprivation also low, AVP response was present. This is the MRI finding. So this is central DI with this MRI finding. The question is, now on follow-up MRI was done again, and then the radiologist said the likelihood of germinoma is very less. So what could be that finding which will say, okay, on follow-up, the likelihood of germinoma is less in this case?
No increase in the size of the pineal gland on follow-up.
Anything else? So what do you see in this MRI? There is a stalk thickening, the very big stalk thickening. So anything else which will give you that this is more likely? So the differential are germinoma versus hypophysitis. I think that's what you are saying. So what will give you that this could be hypophysitis?
Homogeneous enhancement, sir. And
okay, we will come back to you if the other people don't give a satisfactory answer. Dr. Pamali?
Pass.
Pass. Dr. Rajib? Dr. Rajib, you are there?
Yes, sir.
Dr. Guru Prasad?
Sir, in hypophysitis, over the time that the anterior pituitary will shrink, whereas in germinoma, the anterior pituitary will enlarge.
Yeah, so I think that is the question answer I was looking at. So shrinkage in the pituitary size, anterior pituitary will suggest, so this will be a pass marks, 5 marks to Dr. Guru Prasad. Next question to Dr. Pamali. This is the MRI finding. So you just have to tell me what is the diagnosis and how you made the diagnosis. Dr. Pamali?
Yes, sir. Just I was reading the question.
Yeah.
This is a Radke cleft cyst.
Okay, very good. And how do you make the diagnosis?
Sir, the cyst has proteinaceous content, so it enhances after we give the contrast.
Absolutely. So this is a contrast image and there is an enhancement there. So full marks to Dr. Pamali there. So this is Radke cyst. Rim enhancement is the answer. Now the next question is to Dr. Rajib Das. We are showing you two images. One on left side is a abdominal CT scan and the other side is that of a X-ray. You have to tell me same gene is responsible for both the conditions. Just have to name the condition. So this was the CT scan was done in a child who came to you with obesity and growth failure and violaceous stria. The X-ray was done in a girl who came to you with bony swellings and body pain and precocious puberty. So I think the diagnosis will be easier.
Is McCune-Albright syndrome.
Okay, gene?
And PPND.
So McCune-Albright syndrome.
Yes, sir.
Okay, which gene is involved in McCune-Albright?
There are 3 genes: PD, E, MHY, and
I think what do you do? So what is the finding in the first one? If you tell me the finding on the CT scan, I'll give you the marks. Okay, let's go to Dr. Guru Prasad. Let's see what he says.
Macronodules.
PRKRN gene in PPNAT.
Dr. Arun, I'll come back to Dr. Rajib at the end. Dr. Arun?
So this is
Dr. Priyanka, sorry, Dr. Priyanka.
Sir, activating mutation in the GNAS receptor.
Okay. So what we'll do is that we'll give 5 marks to Dr. Rajib because he identified the diagnosis rightly. He said macronodular also. The gene was wrong. So 5 to Dr. Rajib and 5 to Dr. Priyanka. I think both of them were right in their own part. So this was basically a macronodular hyperplasia and fibrous dysplasia, both because of a GNAS1 activating mutation. 12-year-old, this is direct question to Dr. Guru Prasad. 12-year-old boy with short stature, height is very short. This is the finding. Which diagnostic test will you do? Single test will give you the diagnosis. Blood test.
The serum prolactin. Hello.
Dr. Guru Prasad is there. Dr. Guru Prasad?
Yes, sir.
Yeah. So this is the MRI finding of a child with short stature, and we did a single test and we got the diagnosis. What do you see on the MRI?
So you can see the cyst.
Okay. This is an enhanced image. So we'll move forward. Dr. Priyanka?
Craniopharyngioma.
No. Dr. Arun?
So, is it HCG and germinoma?
This is a short stature child, so that was a clue. Dr. Pooja?
TSH, sir.
Absolutely right. So this is actually a pituitary hyperplasia. So whatever you are seeing here is not a mass. This is basically a pituitary enlargement. And this is most common in this setting will be hypothyroidism. So TSH will give you the diagnosis. So we'll give 5 marks for Dr. Pooja for the correct answer. The next question is to Dr. Priyanka, I think. Dr. Priyanka, so this was TSH. 6-month-old child, failure to thrive, pigmentation, and hepatomegaly. So there is organomegaly, failure to thrive, and pigmentation, hyponatremia, and hyperkalemia. So I think we know where we are heading. This was the routine X-ray which was done in this patient. Now you have to tell me which simple routine test will give you the diagnosis. You look at the X-ray very carefully. Maybe not at the chest, but somewhere else also. So a child with failure to thrive, pigmentation, hepatomegaly, hyponatremia, hyperkalemia, this X-ray finding, and we did 1 blood test, gave the diagnosis. So, Dr. Priyanka, look at the X-ray carefully.
Barium swallow. Achalasia cardia, sir.
Dr. Priyanka?
I'm not able to hear you. Hello.
The pass.
Dr. Priyanka? एक बार देखिए Dr. Priyanka. Dr. Priyanka, are you there?
Yes, sir.
Yeah. Did you get the question?
Yes, sir.
So you have the answer: failure to thrive, pigmentation, hepatomegaly, hyponatremia, hyperkalemia, and this X-ray finding. Which test will help you reach the diagnosis?
The barium swallow.
No. Next is Dr. Arun.
So this is adrenal calcification in
Okay,
Wolman
very
syndrome,
good.
sir.
Very good. So this is Wolman syndrome, and you can see adrenal calcification. Which test will give you the diagnosis? Simple test. Lab
Lipid
test.
profile.
Lipid profile. Excellent. So 5 marks to Dr. Arun there for the correct answer. Now we have got the next case. This is for Dr. Arun. 12-year-old girl with thyroid nodule. TSH was undetectable. This is the this is the scan finding you found. Now, what would be the further management? So when I say management, it doesn't mean treatment also. It can mean you want to do some other test as well. So based upon this sort of a scan finding, what would you like to do? First of all, what do you see, and that will give you the guide the diagnosis?
So this looks like a solitary nodule.
Okay. Yeah.
Functioning hyper functioning nodule. So initially we have to stabilize the child with beta blockers and antithyroid drugs, and final management is surgical management.
Okay, we'll move forward to. I wanted a better answer on that, so we'll come back to you if required. Dr. Pooja,
Yes, sir.
do you agree with the treatment, or there's something else in this scan?
Toxic adenoma, it is looking like, sir.
Yes.
Preferable treatment of choice is radioiodine. Actually, age is a bit usually
Okay, no worries.
beyond
We'll go forward. We'll come back if required. Dr. Pamali?
So it is a toxic adenoma. The management, because first we have to control the hyperthyroid state.
Okay, fine. I am looking for something else. Dr. Rajiv? Dr. Rajiv, are you there? Dr. Guru Prasad?
Sir, is there a coexisting cold nodule?
Okay. So you tell me, what do you want to do?
So suppose if there is cold nodule, we have to do a ultrasound guided FNAC.
I think that's what I was looking at, because if you have a toxic nodule, the entire thyroid gland should have been completely suppressed. So this is more like a warm nodule / an area of in which there is nothing there. So this could be like a warm nodule where your FNAC will be required. So you should have got the FNAC done, and 5 marks therefore, Dr. Guru Prasad. So while we are moving forward to the audience question, Dr. Dhwani will collate the results. 3-year-old boy with polyuria, low urinary osmolality, sodium is high, post DDAVP urinary osmolality increase. So this is central DI. This is the X-ray finding. Now, what the audience can write, what examination will help to achieve the diagnosis? So Dr. Deepak has written histiocytosis. So what examination finding? Rash and seborrhea. Dr. Nikhil Sanjeev is saying LCH skin lesion. So yeah, so Dr. Aniket, so correct. This is a LCH, seborrhea or rash will give you the diagnosis. So Dhwani, what is the score at the moment for the second round now?
Dr. Pamali at 20 points. Dr. Arun George and Dr. Pooja Tiwari at 15 each. Dr. Guru Prasad at 10. And Dr. Priyanka and Dr. Rajitram at 5 each.
So it's going on well. We'll carry forward for the next round, which is labeled as diagnostic dilemma. So we will go on to this case and this will start. Yeah.
Excuse me, sir. Actually, I think my score is 25, sir.
Arun is 25, I think. Sorry. So Arun is 25. We are mistaken. So can you speak again the score?
Sorry about the error. Dr. Arun George at 25. Dr. Pamali at 20. Dr. Pooja at 15. Dr. Guru Prasad at 10. And Dr. Priyanka and Dr. Rajiv at 5 each.
Okay, sure. So now the direct question is for Dr. Arun. 16-year-old girl with recurrent hypoglycemia, very low blood sugar. GIR is requiring is very high, 12 milligram per kg per minute, and it persisted in the hospital. So it's not that you started and she became fine. She is non-ketotic. Insulin and C-peptide is undetectable. So what will be your further investigation? And first, of course, what are you thinking about in this case, Dr. Arun?
Sir, this child has, it looks like an insulin-mediated hypoglycemia. So since insulin and C-peptide is undetectable, so it is a post-receptor problem, either AKT2 or PI3K mutations will be the
Agreed, but this is 16-year-old girl. So think something else. You are in the right track.
Okay, so it can be a insulin receptor antibody will be possible. So I'll work up for the antibody for insulin receptor.
Okay, absolutely right. So this is looking like apparent increased insulin effect, but there is no insulin. So this is an insulin antibody like TSH receptor antibody. Similarly, insulin antibody can cause this. So full marks to Dr. Arun. at that point of time. Next question is to Dr. Priyanka. 18-year-old boy with gynecomastia. SPL is 3.2 centimeters. Pubic hair is stage 2. Testicular volume is 25. So this child comes to you with gynecomastia with large testis and micropenis. LH is high, testo is high. So both of them are high. Genetic shows partial AIS. So we have given you the diagnosis. Now somebody has started a high dose testosterone to see what is the response clinically. Your question is, what will be the biochemical test which will give you the response to testosterone?
So the response to testosterone can be assessed by assessing the sex hormone binding globulin levels.
Okay, so that should go down or go up with testosterone treatment?
So that should go down.
Okay, perfectly right. So 10 marks to Dr. Priyanka. That's a good answer. So it's a biomarker of testosterone. Next straight question is to Dr. Guru Prasad. 18-year-old boy with papillary carcinoma thyroid, diagnosed at the age of 14 years, had underwent surgery, radioactive iodine ablation, thyroglobulin is 0. But somebody got a radioactive iodine scan which showed a tracer uptake in some parts of the body. So why do you think this could be a discrepant result, and what should have been done to avoid this?
So there could be antibodies to thyroglobulin.
Okay.
So that has neutralized the thyroglobulin, and it could be de-differentiated kind of thing.
Sure. So we should do a thyroglobulin antibody here. So again, 10 marks to Dr. Guru Prasad. Next question to Dr. Rajib Das. 10-day-old girl with abnormal thyroid functions. FT4 is 7, TSH is 6. So FT4 is low, TSH is not very high. She is actually 30 weeks of gestation. Postnatal period was uninterrupted. So this is a preterm baby. There are no features of MPHD. What will be your next step you want to do before you initiate treatment, or what is your next plan? Dr. Rajib? Dr. Rajib?
Sorry. FT4 is low and TSH is low. So I have to perform the repeat test after 2 weeks or at the term.
Okay, repeat test, or you want to, so this looks like a central, you think this is central hypothyroidism or something else?
It is but there are no features of central, physical features of central.
So you want to repeat it after some time?
If in case of preterm?
Yes, you want to repeat it. Okay. We will consider that. We'll go forward and see if we have a more precise answer. Dr. Pamali?
So there could be two possibilities. First, we could try with a different method like equilibrium dialysis for free T4 levels. Or it could be a transient hypothyroxemia of prematurity.
So I think you are the right answer. That's what we are looking at. We wanted to get a FT4 clarified via equilibrium dialysis, because this FT4 may not be good enough at this point. To 5 marks to Dr. Pamali here. Now the next question is also to Dr. Pamali. 18-year-old girl with hirsutism and oligomenorrhea. High testosterone levels were there. PCO appearance was there. She was started on estrogen and progesterone. Now, apparently the parents are very worried. There is no clinical response. So you have to tell them using a biochemical marker whether the response is there or not in this girl on estrogen and progesterone for PCOS.
Free testosterone, I would like to do.
At what time? At what time?
Early morning in the follicular phase of the cycle.
So now she is on OCs, estrogen progesterone. So when will you do? When she is on estrogen progesterone, when she is off?
Then she's off the OC cycle.
Perfectly fine. So at the end of the last dose, you can do a free testosterone, typically 3 months after initiation, to get the right diagnosis. So this was a correct answer. So this will be a full marks to Dr. Pamali. Now, final question in this round is to Dr. Pooja. 10-year-old girl with hypothyroidism on thyroxine 100. TSH is FT4, is 54, very high. She has good compliance. Clinically, she looks euthyroid. So you say, okay, I want to repeat the test. And the lab does it again, it is 2.5. What do you think would have caused this so much discrepancy here? Which analytical error? So I'm very specific. Which analytical error could have explained this? Dr. Pooja.
Heterophile antibodies.
Heterophile antibody. So this was on the same platform.
Okay.
So on the same machine, you send it back.
Carryover.
Yes. So it is basically a carryover effect. Perfectly right answer. So again, full marks to Dr. Pooja. So while you tabulate the answers, we will get the next audience question, which is 17-year-old girl with hyperandrogenism with very high FGS. She was known as PCOS for a long time, had poor adherence, is virilized, has a very high testosterone, and you can see very large ovaries. So what treatment you can give other than estrogen, progesterone, and metformin in this case? Spironolactone, we want something more. This is much more severe. Virilization is there. So what is happening here? So GnRH analog cyan because of hyperthecosis. So this is ovarian hyperthecosis, an emergency. If you don't treat it, there will be a lot of other problems. So while we are finishing the round 3, Dr. Dhwani will tell us the score.
At the end of round 3, we have Dr. Arun George and Dr. Kamli Nanda both at 35 points. We have Dr. Pooja Tiwari at 25 points, Dr. Guru Prasad at 20, Dr. Priyanka at 15, and Dr. Rajat Das at 5 points.
So as I said, don't worry. The final round can give us a huge score bump up and down. You can have plus 60, minus 60. There's still 2 rounds left. So we will quickly move forward to the 4th round, which is a therapeutic dilemma. So we are talking about newer treatments which are available. This will start again from Dr. Pooja. So the first question, Dr. Pooja, is, this is a 12-year-old boy with obesity. You know the diagnosis: developmental delay, hyperphagia, infantile hypotonia, and there's Prader-Willi syndrome. Now, recent studies have shown an inhaled treatment to be effective in this condition. So you have to name that, Dr. Pooja. So inhaled therapy, which is effective in preventing hyperphagia. I'll be more precise. So Dr. Pooja?
Octreotide.
No, we will move forward to Dr. Pamali.
Setmelanotide.
No, Dr. Rajiv. Dr. Rajiv. Dr. Guru Prasad.
GLP-1 agonist.
No, inhaled therapy. You have to think about the word inhaled. Priyanka. Dr. Priyanka. Dr. Priyanka, you're not answering?
No, sir. Pass.
Yeah, Dr. Arun?
Sir, nasal oxytocin therapy and
okay, perfectly
oxytocin
fine.
and carbetocin as well.
Yeah, so oxytocin is the right answer. So Prader-Willi syndrome, oxytocin. I think that's a wonderful answer. 5 marks to Dr. Arun for this. Next question is to Dr. Pamali. 16-year-old girl with type 2 diabetes. She has high HbA1c, on insulin, metformin, and sugars are not getting controlled. There's a family history of MCT. So medullary carcinoma thyroid, you cannot use GLP-1 receptor analog. The question is, which recent drug has been approved recently by FDA, a oral agent in type 2 in adolescents? So Dr. Pamali?
Semaglutide.
Not yet.
Okay. GLP-1 receptor.
Not yet.
No.
Dr. Rajiv? No, your answer is that. Dr. Rajiv?
SGLT2 inhibitor.
Okay, yes. So we have got the empagliflozin, which is the SGLT2 inhibitor, which has recently been approved by FDA. So 5 marks to Dr. Rajiv for the correct answer. Next question directly to Dr. Rajiv. 12-year-old girl with type 1 diabetes, diagnosed 4 years ago on basal bolus regimen. HbA1c is high. They have heard of a weekly insulin. That a weekly insulin has not come up, a basal weekly insulin. You have to tell me the name of the weekly insulin and how has it been prepared. So Dr. Rajiv.
its name I just forgot, but there is hexamers, or
No, we'll move
there is slow
forward.
release of the insulin. That is
We'll move forward. Dr. Guru Prasad?
No, sir, pass.
Dr. Priyanka?
Pass.
Dr. Arun?
So the name of the insulin is Icodec.
Yes.
So the modification, I'm not very sure, sir. Like I know it's weekly insulin, 70 mg once weekly.
Okay, fine,
Recently
we'll give it
published
to
in
you. So it is basically based upon the same principle of structural modification, increasing the binding to albumin. So it adds the fatty diacid chain. So it's once a week. It's been studied in adults already. So good answer on that. So we'll pass it on to Dr. Arun. Next question to Dr. Guru Prasad. 14-year-old boy with obesity, weight is 120, BMI is 43, normal workup, fatty liver, so he has all the complications. There is a novel dual GLP-1 receptor GIP analog which has come in, which is not yet approved in children, but I want you to name that, which has been used very effective in obesity in adults. Dr. Guru Prasad?
Tirzepatide.
Okay, very good.
Tirzepatide.
Yes, you got the answer. So 10 marks to Dr. Guru Prasad. So this is a novel dual GLP-1 GLP agonist which has been found to decrease BMI by 20%. BMI decrease. So this is something which is quite effective. Direct question to Dr. Priyanka. 6-year-old boy with recurrent sweating and palpitations had congenital hypertrophic pyloric stenosis, hypoglycemia, ketones were low, insulin was high. So this is a hyperinsulinism which is there. Novel therapy has been found to be most effective in this condition. So you name the drug and the mechanism. Dr. Priyanka? So what is this happening here? Which type of hyperinsulinism are we dealing with here? So Dr. Priyanka, you are there?
Yes, sir. Sir, pass.
Okay, Dr. Arun?
Sir, this is because secondary to the surgery. So this is like so most effective therapy would be GLP-1 analog, sir, Exendin.
GLP-1
or otherwise,
so I'll give it to you. It's Exendin, which is
right.
acarbos are not very effective, but yes, that is an option. But GLP-1 receptor antagonist basically. Exendin is an antagonist which is there. So I think that both analog can be antagonist or agonist. So we'll give you the answer there. So Exendin, it will inhibit the insulin incretin effect basically. Last question, I think for the direct one is to Dr. Arun. 8-year-old boy with tetany, calcium is low, phosphorus is high, creatinine is normal, PTH is low. So the diagnosis I think is reasonably there. Calcium and vitamin D was given, with which he developed polyuria and hypercalciuria. Now, which novel treatment is safe and effective in this condition? First, which is the condition and what treatment will be more effective? Dr. Arun.
So this is hypoparathyroidism.
Okay.
The novel therapy would be teriparatide.
Okay, we'll go forward to Dr. Pooja.
Or sir, this is CSR.
No.
Because there's hypercalcemia. Sorry.
Yeah.
CSR mutation.
We'll stop there. Yeah, we'll come back to you. I'll come back to you if I feel the answer is right enough, good enough. Dr. Pooja, I'm mainly interested in the treatment. Dr. Pooja.
Recombinant PTH, sir. 1 to 34.
Okay, so you want the full PTH or the teriparatide?
No, sir. Recombinant 1 to 34 amino acid PTH.
Okay, so basically what is the difference here is that the only one which is recommended is NAT-para, which basically is the entire PTH rather than the teriparatide. So we will now, and what was the diagnosis? If you get the diagnosis correct, we'll think about the answer finally.
So this is CSR mutation, sir. Gain of.
So this is a calcium sensing receptor. So we'll give 5 marks each to both of them. because the answer for that was right. And then teriparatide is actually not recommended. People tend to use it, but better would be the natural or the recombinant version. Natpara will be the one. So we'll give 5 marks each. Before we have the final standings before the buzzer round, the audience question is 2-week preterm neonate, hypercalcemia, hypophosphatemia, low PTH, vitamin D is low, calcitriol is high. What is the therapeutic strategy you will work out on that? So Dr. Anju Bala is saying phosphorus, Sayan is saying phosphorus. True, this is hypophosphatemia which is causing this. So I think before we go ahead with the buzzer round and try to close it, we'll have the scores here.
55 points. Dr. Pamali at 35. Dr. Guru Prasad and Dr. Pooja at 30 each. Dr. Priyanka at 15 and Dr. Rajit Das at 10.
So still anybody can win. If you can score 60 points, you can get there, or you score minus 60, you can go the other way around. So buzzer round, basically, we will explain again as to how the buzzers will work on it. So what we will do is that we will use the chat option for that. So all of you can please open the chat option. I will write a N and this will reset the question. And then you have to write Y. So all of you please write a Y and enter in the chat. Dr. Arun, Dr. Pamali, I've got that. Dr. Guru Prasad, I've got it. Not as a direct message, please write as a Dr. Priyanka, you write for everybody. Dr. Pooja, Dr. Rajib. Yeah, so write it for everybody, Dr. Guru Prasad and Priyanka, not for me. So you write it for hosts and panelists. Yeah, everyone you can write basically. So Dr. Priyanka and Dr. Guru Prasad, you write again, not to me directly, but write to everybody. You can retry. Yeah, so Dr. Guru Prasad, I've got direct message, and Dr. Priyanka, yes. So I'll put a N, which means that now the question will be open. As soon as you get the question, you have to stop there and give the answer. No thinking. Plus 10 for a correct, minus 10 for a wrong answer. And we have seen last quiz how things can change quickly. So first question on buzzer, 15-year-old girl with osmotic symptoms, no ketosis, variable insulin requirement, lean, no acanthosis. This is the ultrasound. I want the genetic diagnosis. Anybody? Dr. Priyanka?
Sir, HNF 1 beta modified.
Okay. So this
Renal
is
cyst
HNF
seen
1
on the
beta,
ultrasound.
correct. So 10 marks to Dr. Priyanka. Good. So that was the right answer there. So next, I am resetting it again. And
Can
now
you please make it full screen?
Okay. If I make it full screen, yeah, I'll make it full screen. You can look at the chat then. Yeah. So next question, this one we have already done. So this was HNF 1 beta. 2-year-old boy with developmental delay, hypotonia, spastic paraplegia. T3 is 120, T4 is 60, TSH is 7.4. So T3, 120, T4 60, TSH 7.4. What is the treatment? Dr. Arun?
So this is Allen Hernan Dudley syndrome. Treatment is Triax.
Triax. So this is correct answer. 10 marks to Dr. Arun. So I think this is a very characteristic finding where T3 will give you the clue. I'll reset the chat option, I think, again. So I've reset it again and we will move forward to the next question. 17-year-old boy with delayed puberty, stalled puberty, 2 ml and shorty testis. FSH is 32, LH is 15, testo is low, karyotype is 47XXY. Recent onset virilization and a high testosterone levels were found. Which test will give you the diagnosis? Dr. Arun?
This is in Klinefelter, probably a HCG secreting tumor.
Okay, perfect.
HCG,
Yes.
I would like to.
So if you have virilization in Klinefelter, you have to think of a HCG tumor. So HCG level will give you the diagnosis. So 10 marks to Dr. Arun. So I think that's going on very nicely. So you have got 3 questions. next question we will have the score so that we can strategize as to who will answer the questions that way. So I'm resetting it again. So the next question basically is 2-year-old girl with failure to thrive, weight is 8, height is 68, sodium is 154, potassium is 6.2. Which disorder is caused by decreased effect of this channel? Dr. Rajib. So the question is which disorder is caused by decreased effect of the implicated channel? Yeah. Dr. Rajib.
Yes, sir. Sodium chloride imported defect.
Okay. So we said this is because of increased effect, which disorder is caused by decreased effect?
So Gordon syndrome. In Gordon syndrome, there is hyper.
So this is Gordon syndrome, but what is the opposite of Gordon? Just final chance. Opposite of Gordon, same disorder, but opposite picture.
Sodium potassium use both low. In case of diabetic use, there is they have to be both low, and butters.
Okay,
no
so
butter. It has no, sir. That is Gentleman syndrome can be.
okay, we will. What do you think? We should give that. Gentleman syndrome is the answer. So we'll give 10 marks.
Yes.
I think you are in the right track. You got confused with Gordon, but this is gentleman. So that the question was a bit tricky. But anyway, gentleman is fine there. We will reset the point here. And meanwhile, while we reset it, we'll have the score of this stage.
Dr. Arun at 75, Dr. Priyanka at 25, Dr. Guru Prasad at 30, Dr. Rajat Das at 20, Dr. Kamali at 35, and Dr. Pooja at 30.
So there's a lot of competition, especially for the second place. Maybe for the first place also there is a slight chance, but I think second place there is a big fight which is there. So I have reset it. I'll reset it again. We have the 2 more questions to go. So the next question is 6-year-old girl with refractory rickets, normal growth, no malabsorption of medication, calcium is 7, phosphorus is low, blood gas is normal, vitamin D is 8 nanomoles per liter, but despite giving IM vitamin D, it is not increasing. Dr. Rajib?
Normal growth, normal growth.
You should answer immediately.
Hypophosphatemia.
No, this is the wrong answer. Anybody in the audience? So this was a bit confusing. 25 hydroxylase deficiency, because even if you're giving IM, it is not increasing. So minus 10 to Dr. Rajib. I think we've got only one answer left. So we can have a change in the second position. So who are on the contention for second position?
For the second position, we have a close competition. We have Dr. Kamali Nanda at 35, Dr. Pooja and Dr. Guru Prasad at 30 each, and Dr. Priyanka Gupta at 25.
So all of them can have a jump on this. So the last question is very crucial from the second position perspective. We should all go for it, I think. So I'll reset it. One person who will be very happy, who already don't need to do anything, is Arun, who is already sitting there nicely. So before we go ahead with the last question, keep your hands on the buzzer. 18-year-old girl with amenorrhea and galactorrhea, LH is low, FSH is low, TSH is 3.2, prolactin is 34. This is the MRI. What is the plan? Dr. Arun? So Dr. Arun, what will you do?
So this is probably because a patient has galactorrhea, I would suspect hook effect and do dilution, so prolactin in dilution.
Yes, so I think that's very good answer. This is dilutional cause because there is a large lesion and the prolactin is not high enough. So I think with that we come to the close of this program, and Dr. Dhwani will give us the final scores there.
So it was an amazing quiz, and at the end of it, we have Dr. Rajat Das at 10 points, Dr. Priyanka Gupta at 25. We have Dr. Guru Prasad and Dr. Pooja Tiwari at 30 each. At the second position, we have Dr. Pamali Nanda with 35 points. And Dr. Arun George is the winner at 85 points.
Big round of applause to Dr. Arun George. We'll have your feedback. Dr. Rajib.
It was a wonderful experience. I've learned a lot from the quiz competition.
Yeah.
But I have to do more better.
Yeah, no worries. Dr. Guru Prasad.
I think I can feel my age now because I'm not able to concentrate and I'm not so fast now in analyzing. So age is catching up. But anyhow, thank you, sir, for all the things. Thank you.
Thank you. Dr. Priyanka.
They need a lot of revisions and a lot of reading before giving
but
the
I
test.
think, yeah. So Dr. Pooja.
Thank you for allowing, sir. It was very wonderful experience and learning experience also. Thank you so much.
Thank you, Dr. Pooja. And Dr. Pamali.
So it was a very wonderful experience, and we were like at the tip of our toes. So it was very good opportunity, sir.
Thank you. And finally, Dr. Arun, who is now a veteran. Probably next time we will not allow you to be part of the quiz 3 times already. So you can share your feedback. Or maybe next time we'll make you a quiz master as well. So you'll make some questions.
Yes. Thank you very much for this opportunity, sir. Like from my MD days, now I'm currently like almost finishing my second year of DM. From my MD days, I've been watching your, started with watching YouTube videos. Then when I joined the DM course, then I got to join your online course as well. So I'm sure I have learned quite a lot from you, sir. And I would say, like, though in this quiz, Pamali ma'am has scored less than me, but her knowledge is actually much more than me. We last 1 week, we used to sit together and we were preparing, me and Pamali ma'am, and I would say she would go page by page of spelling and like teach me actually. Like her knowledge is way more than me. And I would like to thank even Dr. Sayan Banerjee also. So he is your student, and he is my colleague here in PJ. So he has also helped us, and I would really like to thank my teachers in PJ and my colleagues in PJ. Thank you very much for all the knowledge that you share with us, sir. Thank you, sir.
Thanks a lot. And it was a wonderful performance, I would say. And congratulations. Thanks again to the entire team, all the audience who are sitting here and globally who are there, especially to Dr. Vibha, Dr. Dhwani and Dr. Alapan. And thanks all. We will close the session and our team will contact you with regards to the prizes and how we'll allocate them. Thank you. Yes, pleasure.